American Society of Hematology has a really great webinar series on new agents in hematology, and it is a live session here at ASH 2015. And to talk about this, I'm with Dr. Mikkael Sekeres, MD of the Cleveland Clinic, but for our purposes, I'm more happy to say he's the editor-in-chief of ASH Clinical News. First, thank you very much for some time. And these are some new agents. I mean, in the first case, it's one that just was approved in October, and it's a reversal agent for the effects of dabigatran. That one I know in cardiology, that we've been looking forward to it for a while. How about in hematology?
So it's an interesting drug and an interesting indication. Dabigatran, of course, is used as an anticoagulant in patients who have atrial fibrillation or in patients who've had a blood clot. Sometimes these folks are on an anticoagulant and something terrible happens. In Cleveland, they might be walking out on the sidewalk, slip on some ice, fall and hit their head and develop an intracranial hemorrhage. They come to the emergency room, and up until now there hasn't been an effective agent to reverse that bleeding. Well, we have one now in the form of idarucizumab. And it's a drug that works. The testing that they did on it in a clinical trial showed almost 90% of people had a reversal of the
dabigatran, yes, exactly.
Yeah.
And in this case, we probably should note that the inclusion criteria of the pivotal trial was chosen to mirror the real-world population to which the reversal agent would be used. So I think that's fairly important. In cardiology, there has been not the widespread use of these agents as they thought at first, and maybe part of it was they were waiting for a reversal agent.
Well, it could be. You know, it's tricky, and this is a point that Ken Bauer actually raised when he gave his presentation today, and that is that this is an expensive drug.
Yeah.
And you first have to define what constitutes an emergency or an urgent indication for it, and then where are you going to stock it? If you're at a big place like Cleveland Clinic, sure, we're going to see these patients and we're going to stock it in our main hospital. But if you're at a smaller institution, is it worth keeping this drug on the shelf when eventually it may expire and you'll have to absorb the cost of that drug?
Yeah, that's a really important issue. So the second new agent is from about a year ago. It's for a treatment for Philadelphia chromosome negative relapsed refractory precursor B-cell acute lymphoblastic leukemia, and it is blinatumomab. And how's that agent? Is that one that is going to be doing some good things?
Yeah, so we've actually used this agent a lot. Blinatumomab is a monoclonal antibody that works in patients who really don't have any drugs approved for what they have. These are folks who have acute lymphoblastic leukemia. About 40% of them we can cure, but that means that about 60% we can't. And all of those folks are destined to either relapse or die. For these patients, we finally have a drug that's approved that really does work and works for a durable period of time. As with the other drug, one of the challenges with this one is it's very expensive, and it requires an inpatient stay and then a transition to outpatient. And this has logistically been very challenging for a lot of cancer centers to institute. Also, as with the idarucizumab, this drug was approved based on an accelerated approval pathway, which means that there is a phase 3 study with a more clinically meaningful endpoint. So instead of just response rate and durable response, survival, and we're waiting for the results of that to come out.
Now there's a third and final agent. It's one approved early this year for the treatment of patients with multiple myeloma. We've got a variety of new agents for multiple myeloma. This one, you pronounce it so well.
Panobinostat.
Very good, thank you. So where does this one fit in?
Well, panobinostat was approved as part of combination therapy, again based on interim markers of clinically meaningful benefits. So we're waiting for a phase 3 study with a more durable endpoint to emerge as well. This is exactly the question that I asked Sagar Lonial, who's the person who presented it. And he sees a real role for using this drug in combination with bortezomib and in patients, and with dexamethasone in patients who have failed a former immunomodulatory drug. So he uses it in folks who he thinks have more of a proliferative multiple myeloma.
Given the world we're living in today, are these high-priced drugs really going to complicate things, or are you still optimistic as we look ahead?
Yes.
You're optimistic, thank God.
And they're going to complicate things at the same time.
Right on both counts.
And again, I'm not a multiple myeloma doc, but we're actually going to have a session on Monday where FDA is going to talk about the new approvals in multiple myeloma, so we can get more of a sense of how exactly we should be using them and in what order we should be using them.
Well, please go pull out a copy of ASH Clinical News or go online where you also see this video for more from your editor-in-chief here. And for ASH Clinical News, I'm Rick McGuire.